All right, well, it's 12:01, so I'm going to jump right into introductions. So it's with great pleasure that I introduce to you Dr. Barbara Rothbaum for our both Roybal and CVCH Grand Rounds. Dr. Rothbaum is the director of the Emory Healthcare Veterans Program. She's a professor and associate vice chair of clinical research at the Emory School of Medicine and the Department of Psychiatry and Behavioral Sciences, and she directs the Trauma and Anxiety Recovery Program. She's truly a true specialist and expert in research in PTSD. And among her many accomplishments, she helped invent virtual reality exposure therapy and pioneered its application to the treatment of PTSD in combat veterans. She was an author of the Institute of Medicine's study on the assessment of ongoing efforts in the treatment of PTSD. And just thinking about true policy impact, she presented this work to the Department of Defense, the VA, and the House and Senate committees on Veterans Affairs and Armed Services committees. She's authored over 400 scientific papers, numerous chapters, as well as many books on the treatment of PTSD. She's past president of the International Society of Traumatic Stress Studies and is currently on the scientific advisory boards for the Anxiety Disorders Association of America, the National Center for PTSD, and on the executive committee of the Warrior Care Network. There's many other recognitions I could go on with, but with that, please welcome me in join me in welcoming Dr. Rothbaum to this week's Roybal Center Grand Rounds, and I'll pass the mic to Dr. Rothbaum.
Thank you, and I'll share my screen and just making sure.
Yep.
All right, so I'm gonna, first my disclosures. So as Ian said, this work, we published the first study using virtual reality as exposure therapy for a psychiatric or psychological disorder in 1995, and Emory and Georgia Tech Better. And I'm a full-time at Emory, but virtually better is my conflict of interest. The virtual Iraq that I'll talk probably the most about was created by Skip Rizzo at USC, and the Emory Healthcare Veterans Program is supported by a grant from the Wounded Warrior Project. So I'm gonna start with this. This is a study we did a long time ago, but it's still in, probably you all know, PTSD became an official diagnosis in 1980, and it was really in response to a large number of Vietnam veterans who were suffering. So in 1980, it was already, we wanted to do a prospective study in females. So we met with female rape victims right after the assault and assessed them every week for 12 weeks for 3 months. We were surprised to see in that first week, in the first few days following the assault, 94% of them met symptomatic, not duration, but symptomatic criteria for PTSD. So part of what that said to me is PTSD is the normal response to trauma. Somebody holds a knife to your throat and says, don't scream or I'll cut you. You're going to have problems sleeping and problems concentrating. You'll be scared to go outside by yourself. All of that's normal. So we wanted to figure out when a normal response to trauma ends and a psychopathological response that requires a diagnosis and treatment begins. So we followed people over time, and we were still surprised to see 12 weeks later, 3 months later, almost half met full criteria for PTSD. So then we divided it up and went backwards. So we divided it up according to their PTSD status at week 12, and tells a little bit different story. The top line represents people who end up with chronic PTSD. The lower line represents people who don't end up with chronic PTSD. And if we want to use the term recover, we can use that loosely. And then you see, so everybody comes down a lot in the first 4 weeks. After that, the folks who recover, they continue to improve steadily across time. Whereas if you look at the top line, after week 4, the folks who end up with chronic PTSD, they don't change. They don't get worse, but they don't get better. And so this has led some of us to think of PTSD as a disorder of extinction. Fear and anxiety is a normal response to trauma. For most people, that fear will extinguish over time. For a significant minority, it won't. The good news about that, there's not a lot of good news in it, is that we know a lot about extinction training from the animal literature, and in humans, we call it exposure therapy. And just very simply, what exposure therapy is helping people to confront what they're scared of, but in a therapeutic manner so that something changes. If they just go and they scare themselves and they run away, nothing has changed. change. That's not a therapeutic exposure. I love this quote by Mr. Rogers. Anything that's human is mentionable, and anything that is mentionable can be more manageable. When we can talk about our feelings, they become less overwhelming, less upsetting, and less scary. And he's basically described exposure therapy, and we've described it in some manuals and books as well. And an online course that the coupon, if anybody wants to take it and get a discount, that you can say PTSD Rothbaum. So in general, for prolonged imaginal exposure, the theory behind it, we think in terms of an emotional processing theory. When something important to us happens, we need to emotionally process it. I make a lot of analogies to the grief process. There's no way to the other side of the pain except through it. Again, we think that fear is a normal response to trauma, but this fear and anxiety and what I call social conventions can lead to avoidance. So if I get scared when I go outside by myself, maybe I stop going outside by myself. What I mean by social conventions is our society's really not very good about talking about negative events, and certainly not the kind of events that lead to PTSD. And I think people are given the message implicitly and sometimes explicitly, go on with your life, forget about it. In other words, stop talking about it. And I think this is a large part of what happened to the Vietnam veterans. They came back, it was an unpopular war, no chance to talk about it or debrief. And it's a cliche, but the long boat ride home of the World War II veterans, I think was actually very therapeutic. In general, they stayed with their unit. They were together for weeks. They got to decompress, debrief a little bit. And when they got back to the States, I think they were a little bit more ready to re-enter society, and they re-entered society as heroes. People wanted to hear some of their stories. So all of this avoidance is reinforced, but that prohibits the emotional processing. And then that's how it haunts us. And so we think for good emotional processing, you've got to activate it. You've got to bring up the memory, but you got to put it back differently. All the kids in my team are tired of hearing me saying, what does the patient need to learn? So you want to put it back with some new learning. For the most part, imaginal exposure works pretty well at activating that memory. What we do in imaginal exposure is we ask people to close their eyes and go back in their mind's eye to the time of the trauma, recount it in the present tense as if it's happening now. And we record it and give them that recording to listen to. We ask them to usually go through it at least 3 times per session, and then we do it over and over and over. We also do in vivo exposure. That just means in real life. So doing things that are realistically safe that maybe they've been avoiding doing because they remind them of the traumatic event. And then we'll also talk about virtual reality exposure therapy. I'm not going to go through all the evidence for exposure therapy. They've got a lot of different ones, different cultures. The PE manual has been translated, I think, into like 10 languages now. And it's got more evidence than any other intervention for PTSD, including 2 FDA-approved medications. So now let's get into some new approaches. One's the medium of delivery of exposure therapy. Like I said, it's usually in the imagination.
We will begin takeoff momentarily.
This is the virtual airplane, and actually it's my favorite out of all the virtual environments. I can exactly control the stimulus. If my patient's not ready for turbulence, I can guarantee there won't be turbulence. When my patient is ready for turbulence, I can guarantee there will be turbulence. We can take off and land as many times as we need to, all within my 45-50-minute therapy session and without leaving my office. This is a little clip of the older virtual Iraq and Afghanistan, and I'll show you a newer one in a minute. For the virtual reality hardware, this is an old slide, but it shows it all. So people are wearing a head-mounted display. And that's basically, as you see, like a strappy helmet with 2 television screens, one in front of each eye, a position sensor. So just as my view changes in reality when I move my head, so it does in the virtual reality, and earphones. They're on a raised platform that has a bass shaker, a speaker underneath. So, and there's a monitor. The therapist can see everything the patient's seeing on the monitor, so we can comment appropriately. So for example, this guy is in, it looks like the virtual airplane, and you may not realize it, but a large part of what we experience in the airplane is we feel it. We feel the landing gear coming up. We feel the takeoff. We feel the turbulence. This person is holding a hand track or a joystick to be able to maneuver in the environments. This is what it looks like now. This is at our setup in the Emory Healthcare Veterans Program. And this is what it looks like in more of a private practice office setting. So this was the very first study that anybody had done using VR for a psychiatric or psychological disorder. And we did it with the fear of heights. And it worked on every single one of our measures. Anxiety and avoidance decreased. And what was interesting, we had someone go back and look at all the videotapes of the sessions, and people described all of the same physical sensations of anxiety as they would in a real life height situations. What's also was really cool is that 7 out of 10 of the participants who got the virtual reality exposure therapy by the end of treatment reported putting themselves in real life height situations without us even asking them to. And so that's what's important, is if it translates to real life. This was the old virtual elevator we used in that environment, in that study. Here's one we used about 10 years later in the decycloserine studies, and here's what it looks like now. These were the bridges we used in that first study. One of our patients dubbed this the Indiana Jones Bridge, and that stuck. And here are our current bridges. We can do it for addictions. We can put in their favorite cigarettes, alcohol. They can rate their craving in the virtual environment. We've got smells. We've got a virtual crack house. We've used it as a distraction for painful procedures in pediatric populations. And this, what we used for that first study, it was just a really crude virtual gorilla environment that one of my colleagues had developed for Zoo Atlanta. This is what we use now, and it's much more beautiful and interactive and engaging. We've used it for social anxiety disorder. Let's see, let's see if we can play that. And the therapist can control the audience's reaction. So they can be bored, they can be enthusiastic, like this guy. No, I love this guy. So the therapist can do that. We have different environments. We can have them where you can hardly see the audience, that the lights are in your eyes. We can have people asking questions, cell phones going off. We can load the patient's own PowerPoint presentation into the podium. We can have people introducing themselves around a table. We can use videos of real people or avatars. Like I said, this is probably my favorite. We've done several studies now with the fear of flying, and obviously modeled the airport after Atlanta Airport, busiest airport in the world. Like a real airplane, most of the stuff happens outside the window. And we've compared, this is the virtual reality exposure therapy and pre-post and 6-month follow-up. SE is for standard exposure therapy, where we took them to the airport and used a real airplane, and then this is weightless control. And you can see that they're equivalent. The virtual reality exposure therapy was equivalent to standard exposure therapy and in actual flight data. Another study we did at the 12-month follow-up, 90% of people flew in either or both conditions. And their SUDS, subjective units of discomfort, like between 30 and 40, indicates manageable anxiety, comfortable flight. We've got a version that runs in a smartphone. This is what that looks like. I'm not quite as crazy about it because I like all the extra bells and whistles, but this is what it looks like. Now we'll switch to PTSD. And this was the first time trying VR for PTSD, and we did it for Vietnam veterans, figuring if they were still in the system at that point, they were probably treatment resistant. We created a virtual Huey helicopter that could fly over a jungle or fly following a river or over rice paddies. We had a virtual clearing surrounded by jungle that most of our guys referred to as a landing zone. Might be hard to tell. This is an actual digital photograph of a real Huey helicopter control panel. And it's amazing what people attend to. Our very first patient in it, was a helicopter pilot. And as soon as he got in, he said, I had a patch like that on the back of my helmet. So what we did is imaginal exposure, like we described before, to their worst Vietnam memories, but now with their eyes open, and the therapist is matching what they're describing. This was just an open clinical trial, and it worked in decreasing clinician measured PTSD and self-report measured PTSD. And now a number of folks are using virtual reality to treat PTSD, including my colleague in New York, Joanne DeFede, with the Virtual World Trade Centers, using it in Israel. This was an interesting study someone did using VR for driving anxiety and aggression in veterans. It reduced the anxiety and reduced the anger and the aggression. This is a study someone else did with a intensive treatment program that was effective for PTSD in veterans. That's the red line, and then even more effective when they added the virtual reality exposure therapy. So now I'll talk a little bit about a study we did with MST, military sexual trauma. We did not present the perpetrator. We just presented stimuli that they describe associated with the assault. I thought you might want to see, this is what the therapist sees for the virtual reality. It looks very complicated, but it's really not. All of the scenes that we have to choose from are here on the right. And what we're going to choose is a scene that matches where the patient says it happened. We can change the time of day and the brightness. And again, to match what the patient is describing, we can make it lighter or darker. We can control doors and lights. And it's a scary feeling if you think you're alone in a room and you hear the door close behind you. And we can control all the sounds. This was also just an open clinical trial, but it decreased PTSD, self-report, and clinician rated. You're going to hear, we like to look at more objective measures of PTSD rather than just self-report and even clinician rated or self-report. So we look at psychophysiological outcomes, and we saw a significant decrease in heart rate to trauma reminders before and after treatment, significant decrease in skin conductance and startle response. And I thought you might like to see, everybody likes to see squiggly lines, right? This is pre-treatment on the left and post-treatment on the right. EMG, that's actually the startle response, and that's pre-treatment and post-treatment. Heart rate is next. These are our acoustic startle probes and skin conductance at the bottom. You can see it with your naked eye, the decrease in responsivity. So now let's switch to the virtual Iraq that we've been using a lot. This study was published in 2014. This is just a little, it's basically like a movie clip showing you some of the environments. This isn't how the patient would see it. The patient would be wearing a head mount display, so would be immersed 360 degrees in it. And we would only be presenting what the patient described. So again, you're seeing it, more just like a movie to give you some of the examples, but the patient would be much more immersed and describing. We can present almost anything that a patient describes from Iraq or Afghanistan. We can put them in an MRAP or a Humvee, checkpoint, FOB, forward operating base, medevac them out. Got city scenes with, I think, 3 different mosques that they can go in. In the vehicle, we can put them in whatever position they were in the driver's seat. passenger seat, back seat, or the turret if they were the gunner. We can change the time of day and the weather conditions. So again, we're doing imaginal exposure to their most traumatic memories of Iraq or Afghanistan, where they recount it out loud, repeatedly in the present tense, and the therapist is matching what they're describing in the VR. In this study, we underdosed the exposure therapy because we were really testing D-cycloserine, which is an NMDA partial agonist, not to be confused with MDMA that we'll talk about in a minute. And so we underdosed it to allow the D-cycloserine to facilitate it if it was going to. Before each of the 5 exposure therapy, virtual reality exposure therapy sessions, they were randomly assigned to receive a pill, either D-cycloserine, pill placebo, or a drug with a different mechanism of action that a lot of our patients like, alprazolam, Xanax, low dose. And in general, we did see significant decreases in PTSD symptoms with treatment, which made me happy since we knew we were underdosing the exposure therapy. If you look at the actual group differences, the only thing that was consistent is the folks that got alprazolam had significantly higher severity PTSD at post-treatment and higher PTSD diagnosis at 3-month follow-up. So it confirms what a lot of us have thought, that benzos aren't a good treatment for PTSD, and certainly not if they're undergoing exposure therapy. So now I'll switch and talk about startle, because that's a measure that we like a lot. We created 3 2-minute standard scenes with the virtual reality that we could use, and actually a number of people are using them around the country, as an activation paradigm before and after treatment as an assessment. So, and we embedded startle probes in the scenes and in blue screens in between. And we love startle because it's a translational tool. We like translational research. It's a non-invasive measure, simple 3-neuron subcortical circuit modulated by a motion amygdala, and we can measure it pretty easily. This, my former colleague, Mike Davis, who was one of the amygdala experts in the world, this was how he measured startle, and this is how we measure startle. You may not realize it, but anytime you're startled, you blink your eye. So we can measure that with EMG, and we measure other things as well. So overall, we did see the startle response decrease with treatment. And this makes me happy because I think that reactivity and exaggerated startle response is part of what makes people with PTSD feel crazy. So they can know I'm not in a war zone, yet my body is feeling that same level of threat. So when their bodies are learning to become less reactive with treatment, I think that's wonderful. If you unpack it, the blue is D-cycloserine. So that decrease in startle response was mainly driven by the D-cycloserine. We also gathered salivary cortisol before and after these virtual reality, just for the assessment. And as expected, the cortisol increased after this because we knew it was an activation paradigm, and it stayed higher 15 minutes later. So this is what I just showed you. And now that difference is what we're calling cortisol reactivity. And cortisol reactivity decreased with treatment and stayed lower at follow-up. And that's what I just showed you. And unpacking that post-treatment response. And again, it's mainly driven by the D-cycloserine. So now a little bit on MDMA, and I'm sure you know what it is, but we only say it once, ecstasy, because it's really not ecstasy. Ecstasy is what people get on the street. You don't know what's in it. This is, as I tell my kids, pharmaceutical grade MDMA. And especially Michael Mithofer and Rick Doblin and the group at MATS have done several studies now. And this is their setup for it. I think it's the sweetest PTSD treatment in the world. Exposure therapy is very effective. I wouldn't call it sweet. Their therapy is very sweet. This was in one of the studies, not much of a placebo response, but they're also getting a lot of therapy and a significant MDMA response. When they do a crossover and the placebo folks get MDMA, then they get the same significant reduction. This is probably, one of the papers that really started influencing me. They did a long-term follow-up of everybody who had been in the studies, and it was almost 4 months on average, 4 years on average, and they had maintained their gains. This was a newer study that came out a couple of years ago in the Lancet, and there's no placebo here. It's 3 different doses. And again, when they cross over and everyone gets it, it's still effective. And obviously they just came out with the phase 3 trials. I need to add those slides that were effective. Now they get a lot of therapy. I think they got 42 hours of therapy in those phase 3 trials. Again, we like translational research. So going from the animal studies to healthy humans to PTSD. So we've done some animal studies looking at MDMA and extinction, and it did enhance the extinction of conditioned freezing in mice. Remember, we like fear potentiated startle, and this is the setup. I just think it's interesting to look at for the mice. And we did find that MDMA enhanced the extinction of fear potentiated startle. There was some hint that SSRIs might interfere with that effect. And we did find that acute citalopram, Celexa, blocked MDMA's effect on extinction of conditioned freezing. Chronic citalopram, which is how most of our patients take it, also blocked MDMA's effect on conditioned freezing and on the extinction of fear potentiated startle. So this sucks because a lot of our patients come to us on SSRIs, but it's important to know. So they need to be discontinued off of SSRIs if you're going to try MDMA. We have just finished our healthy human study and we're sent it for publication. So if you're reviewing it, please be kind. And again, remember, we view PTSD as a disorder of extinction. So we wanted to see if MDMA would facilitate that extinction. And again, using objective measures. So fear potentiated startle. It was a small study of very healthy people, psychiatrically and medically healthy. And we used pretty much the same paradigm we did in the animal studies. So on day 1, we screen them and evaluate them, but then they get the fear acquisition, the fear conditioning. 24 hours later, they come back, and this is when they're dosed to MDMA or placebo, and that's when they get the extinction training on study drug. And then we bring them back 2 days later for extinction recall. And we use a simple discrimination. So for example, a red square will indicate the aversive stimulus. In this case, the aversive stimulus is an air blast to the throat that's obnoxious, but not painful. And this is what it looks like. And we use a sound attenuated booth. And this is, first they're vitals, but you can see the dark squares are the folks with MDMA, and their pulse rate's increasing. Oops, wrong way. Systolic and diastolic blood pressure. And this is about when we're doing the extinction training. Everybody was able to acquire the fear, and you can see it that they responded to the CS plus, the signal that indicated they were going to get the air blast. Everyone was able to discriminate, and see by the end, they're only just startling to the CS plus that's indicating the air blast, and not to the safety signal. And both groups demonstrated excellent extinction. Again, they were super healthy psychiatrically and medically. What we did find is when we looked at extinction recall, that the MDMA group had more extinction retention responders than the other. So now, obviously, the next step that we're getting ready to try and trying to get some more funding for is combining MDMA with PE, with prolonged exposure, the kind of therapy that we do. So now let's switch to the timing of exposure therapy. So most people know about early interventions, and in general, So post-traumatic stress disorder is the only anxiety disorder, and I still consider it an anxiety disorder, that an external event, the trauma, is part of the diagnosis. So unlike other psychiatric disorders, the precipitant, especially for adult PTSD, is a known event, and it allows us to do something immediately, maybe even preventing the development of PTSD. And working with folks with chronic PTSD, I often hear something that happened immediately after the traumatic experience that either made it better or made it worse. Obviously, we want to make it better. And remember, we view PTSD as a disorder of extinction. The debriefing literature is equivocal at best, some studies showing it can cause harm, and there are really no good candidates for immediate intervention. This is a little bit of a complicated slide, but I'm going to walk you through it because it was a good study. This was by Anke Ehlers and a group in the UK following a motor vehicle crash. And people who scored low initially right after the crash, it didn't matter whether they received psychological debriefing or not. At 4 months later, they're still low. 3 years later, they're still low. The folks who scored high on PTSD symptoms right after the crash, if they got nothing, by 4 months, they were where the other folks were who scored low and at 3 years. The folks who scored high and got psychological debriefing, the way I interpret that, and I think a lot of others, is it looks like the psychological debriefing interfered with their normal recovery, which is not what we want to do. In Mike Davis's lab, he was working with animals and found that extinction training done very shortly, right after fear conditioning, may prevent consolidation of the original fear memory. And he found that when he did the extinction training 10 minutes, so basically right after the fear conditioning, that it prevented, and these are animal terms in terms of the animal research, reinstatement of fear, context specificity, and spontaneous recovery. In his words, it erased the fear memory because these are the indices of the fear memory in an animal model. Obviously, we wouldn't say that in a human model. So we have done some studies in the emergency room, and all of these have been done. If you know Atlanta, you might know Grady. It's a level 1 trauma center. And what we did is assessed everyone. If they presented with a criterion A trauma, we assessed them in the emergency room. We assessed them 1 month later when you can diagnose PTSD, and 3 months after the event when you can diagnose chronic PTSD. So everyone got those assessments, and they were randomly assigned to just get those assessments or to get a modified exposure therapy on top of it. If they got the exposure therapy, they got 3 sessions total. One as soon as they presented in the emergency room, another a week later, and another a week later for the 3 total. And that means they were done by the time they got the 1 month assessment. The protocol is really just a modification of exposure therapy, shrunk down to be quicker and a little bit lighter, because as you probably know, when people have been in the ED all night, all they want to do is go home. And it's an important point if you're doing prospective studies trying to prevent the development of PTSD, there is no baseline for PTSD symptoms. I don't think that it's valid to assess post-traumatic stress disorder within hours of experiencing the traumatic event. And natural recovery is an active group. Most people are going to get better. In this study, the blue are folks that got the early intervention, and yellow are folks that just got the assessment. And so by week 12, by the 3-month assessment, the folks that got the early intervention had half the rate of PTSD as those that were only assessed. And again, this is a complicated slide, but I'll walk you through it. Looking at risk genes, this is done a while ago. We use candidate genes. Everybody will criticize it for that. If they had the resilience genes, the purple and the green, it doesn't matter if they got the intervention or assessment only. They were lower at week 4, lower at week 12. If they had the risk alleles for these genes and they received the early intervention, that's the red line, they look like the folks who have the resilience alleles. The blue line up top, those are folks who have the risk alleles and only got the assessment. So it looks to me like the early intervention may mitigate a genetic risk for PTSD. And obviously this is where the money is. 70% of us will undergo a potentially traumatic experience in our lifetime, but it doesn't mean 70% of us will end up with PTSD. We need to try to figure out who is at risk and then direct our resources and interventions towards them. Interestingly, in this first study, the effect was mainly driven by the rape victims, by the sexual assault survivors, and it was about 30% of that sample. So we did another study, actually it's not in press, I think it was published, I think in 2020, I gotta update the slide, where we wanted to see if one session with homework could work as well as 3 sessions like we did before and compared to an assessment only. And the bottom line is everybody got better. There were no differences between the groups on PTSD or depression. You can squint and try to look for it, but it's not there statistically. Part of the problem, we think, is the reviewers wanted us to just enter people who were at risk for developing PTSD. The measure we developed ended up being a poor predictor of likely PTSD. Motor vehicle crashes were the most common trauma, almost half of our sample, very few sexual assault survivors. And so I think that our sample was most likely to recover. So we weren't able to demonstrate any effects of the intervention. Importantly, though, there were no bad effects from the intervention. It didn't interfere with the natural recovery. So that's good. And obviously we want to develop something that we can deploy in the field into people who are at high risk. So one of the last innovations we'll talk about is the treatment schedule. So most people that would come to me or our folks for treatment of PTSD, they would get treatment, say, once a week, maybe twice a week, but generally once a week. What I want to talk to you now is about an intensive outpatient program, IOP. You don't need to read all of this. This is just a summary slide of a number of reports out there on IOPs. Look at the retention rates. Retention in regular treatment for PTSD is maybe about 50%. There's a high dropout rate. And look at the retention rate in IOPs. So I'll tell you real briefly about the Warrior Care Network and the Emory Healthcare Veterans Program. The Warrior Care Network is funded by the Wounded Warrior Project. There are 4 of us across the country, Operation Mend in UCLA, the Road Home program at Rush in Chicago, Home Base program at Mass General in Boston, and Emory Healthcare Veterans Program. So now I'll tell you a little bit about that. We do have 2 formats for treatment. So we have the traditional outpatient where people will, drive to us, or now maybe telemedicine. The real innovation is our 2-week intensive outpatient program that we are able to bring in. This is for post 9/11 veterans. We're able to bring in veterans from all over the country. We put them up at the hotel across the street, and we give them a lot of therapy every day for 2 weeks. Everything is at no cost to the veteran. We center it on prolonged exposure. This is our building. Everything they need, actually, except the gym, is in our building. We've got a sleep lab on the 4th floor. Our program's on the 3rd floor. We've got brain imaging. We've got TMS machines on the 1st floor. We're using that. Excuse me. We treat PTSD, mild TBI, MST, depression, anxiety. We provide psychotherapy, pharmacotherapy, cog rehab if they've got TBI, stress management, sleep education, sleep studies. Everyone gets wellness. Everyone gets yoga. They can have acupuncture for pain. We, even before COVID, have family groups and family education and family meetings, but we incorporate the family via telemedicine because we really want them eating, breathing, and sleeping our program on site. And we also have a VA liaison. So we have a MOA with big VA, and that gives us a VA liaison that can help them navigate the VA system if they want. Obviously, like most people during COVID, we had to pivot, and we pivoted to tele-IOP, and it worked very well. And you may know about PsyPAC, that has allowed psychologists to practice over state lines in these states. And so we were able to do tele-IOP with folks from a number of states around the country. And we do the same programs, same family, stress management, mindfulness, yoga. This is probably a couple of weeks old, so we've had more than this now, but over 700 have been treated in our IOP. And since April, 154 have been treated, and 55 of them through tele-IOP. This is the number I'm really most proud of, because we have better than a 90% completion rate. Like I said, I think this is the way to treat PTSD. They only have to make the decision once to come here. And if they don't, our veteran outreach coordinator can go across the street to the hotel and knock on the door if they don't show up, and get them over here. So it really is a very effective way to treat PTSD. They're getting a lot of therapy during those two weeks. So at one point we just sliced it, and 2,000 patients had received over 28,000 sessions and over 33,000 hours of sessions. They're getting more therapy in 2 weeks than most people get in an entire year. And it's effective therapy. So again, this is a little busy because we're comparing our tele-IOP to regular IOP. So the green line is pre-COVID, and this is on the PCL, the PTSD checklist. And you can see that we're getting good clinically and statistically significant decreases in PTSD that are maintained. This goes up to 3-month follow-up. And in our tele-IOP, we're getting just as good, if not better in some cases. And this is the PHQ-9, which is a measure of depression, mirrors the PTSD. We're getting good responses that are maintained. This was a different way of looking at it, where we looked at it longitudinally. We assess people up to 12 months post-treatment, and you can see that they are maintaining the gains for 12 months. This is on PTSD, and this is on depression. I'll skip the verbiage. This just got printed, came out in publication, where we're looking at suicidal ideation. And like we thought, and we looked at this with our sister site at Rush, that when you treat the PTSD effectively, the suicidal thoughts decrease. We also have described the IOP. We were getting a lot of people asking us how we did it, so we published that as well. And as you've heard, we like to look at more objective measures of outcome. And what we saw in this study, that the high prolonged exposure responders, that's on the right side, demonstrate a significant decrease in trauma potentiated startle over the course of treatment. And we also see, as I mentioned, I won't go into detail, we've got a subtrack for substance use disorder. They get exactly the same regular program, SUD provider. And we also have a TBI track that's, again, the same. They get exactly the same programming, but neuropsych testing and feedback and cog rehab sessions. Here's some of our team, a teamless plug for my first book for the lay public. It's good for patients, but also good for non-PTSD experts, what everyone needs to know. And you can feel patients, and hopefully we can send them back better. So I will stop sharing, and we can have time for some questions or discussion.
Wow, that was such an amazing talk, and really, really inspiring to see really the focus on patients. And I can imagine, like, some of this seems so responsive to so many of the public health priorities that have come up over the years, is trying to improve from what you've done before and going in totally different directions in terms of the types of interventions. Really, really inspiring. We've had a bunch of sort of comments and questions on the chat, and I know I have a few of my own questions I didn't put in there. I'm going to let Dr. Edmondson had a lot of comments. I'm going to see if he wants to have any specific questions he wants to ask you first.
That was an amazing talk and so inspiring. And I put in the chat earlier that watching this as someone who's mid-career, and a lot of the folks in our center are on the more junior side of the spectrum, seeing someone who has devoted their career to this very systematic, very rigorous, but always patient-focused, always outcomes-focused, impact-focused, and sort of getting better at treating, getting better at helping people be the North Star of the research. I think particularly where we are as a center right now is incredibly inspiring. So thank you for coming.
Thank you.
And modeling that for us. I have lots of different questions, but because I have to give a talk in about 12-15 minutes, I'm going to ask the one that I really want to, need the answer to. We're focused on primarily, at least my work is focused on patients who have had heart attacks, strokes, and then some of our colleagues focused on cardiac arrest and PTSD-like symptoms that develop after these events. And we enroll them in the emergency department. We ask them then what we call ED threat perception, sort of how afraid are you going to die, how out of control you feel, things you would expect. Follow them for a month. We find that somewhere around 1 out of 5 develop, cross the threshold on the PCL. And those people are at increased risk for having another heart attack or dying in a year. And we, Ian has now started this Roybal Center to begin to develop interventions targeted specifically at this type of distress. But we've hit a sort of a wall in terms of, I don't know how to do the VR for this threat that's in the body, this threat that is the body, and I wonder if you've given any thought to that type and sort of how you would approach thinking about it.
Yeah, no, and in fact, I've treated these patients for years. You're exactly right. We call them, cardiac phobic, and that, even when they're told to exercise and their heart rate gets up, it'll scare them, or So I've treated them as PTSD patients and helped with exposure therapy. Something I didn't mention that might be useful. So we got a little bit of funding to create an app for, it's not supposed to be full-blown PTSD treatment or for full-blown PTSD, but ideally, for example, when we were doing our work in the ED, I thought, an app could do this. And we're creating an app now called Messy Memories. And it's basically to try to help process some memories that are causing distress. And it's got some self-care things in there as well, because a lot of times people will isolate, won't exercise, not take care of themselves. The first iteration is going to be partly focused on COVID first responders, but the same skills are going to work for everyone. So we've got it developed. We're hoping to get it in a form and test it probably this fall. And it should be available pretty soon after that. So that might be something even to try, just as a real light touch, just doing some processing of those memories. Because, that's one of the things that we found is the best predictor of who's going to get PTSD. It's the perceptions. And if the perception is, oh my God, I almost died, then they're most likely to get PTSD. If it was like, well, that was not great, but I can, do what I need to do and probably be healthier for it, they're less likely to get PTSD. So yeah, I do see them as PTSD, but you said something interesting. You said that those folks are actually more likely to have another cardiac event. So that's different. And that might mean that they're picking up on something that our biomarkers are not picking up on. So that's, and I never like to BS people. So if you're picking up that they are more likely to have another cardiac event, that's really interesting.
We're not sure about the causality. We think that there's a good chance that a lot of the physiological consequences of PTSD and some of the avoidance behaviors that even you described with your patients with cardiac issues, avoiding exercise, Ian showed that they avoid medications, that this might be sort of a causal thing. So in your experience then, doing exposure with your, what you call cardiac phobic patients, was that successful? What did that exposure look like? Did you have them listen to their heart?
Yeah, so it was, I mean, it's been a handful of patients over the years. So for those few patients, it was helpful. You know, I can't make too many generalizations. If you guys want to do a study, you know, that would be really interesting, and trying some early interventions, or even just any kind of intervention, or even just the app, you know, doing something easy. You know, that would be fun to work with you on it.
Yeah, we've been thinking about the app idea of something we could give to people while they're in the ED, and maybe even their family members, because there is this idea of sort of that one of our investigators, Dr. Cornelius, I don't know if she's on the call today, but she's also thought about, particularly in our patients who come with cardiac arrest who may not remember much of the initial trauma. It's more the re-traumatization through hearing the stories from their partners or their that may be the trigger for them, on top of the, you know, the other aspects of the hospitalization. But really excited to follow up on that.
Yeah, no, for example, even people who don't remember, for example, a motor vehicle crash, and they wake up in the ED and somebody's leaning over and saying, "Oh my God, you almost died."
Yes.
That's what'll, you know, trigger the PTSD, since they don't even remember it. But yeah, it's, I try not to say that to people.
We have a couple questions from other people on our team, so I want to make sure they have a chance. Ali, do you want to say your question out loud, or do you want me to say it when you jump in if you can?
Yeah, sure. I was just, so my question was, you know, I was just curious about whether, you know, this exposure therapy or VR, whether you think that would have a strong influence or any kind of influence on overall on physical activity avoidance due to some sort of traumatic cardiac event, like walking up a set of stairs or a hill or something like that. You know, do you think it would have some an overall effect on fear extinction when engaging in any of those activities in the future?
Yeah, I'm not sure. I mean, it's an empirical question, but also we haven't used the virtual reality when it's just as easy to do it in reality. At least I haven't. I mean, we don't do it just because it's cool. We do it, you know, that's why I like the fear of flying the best. I hated it when I got a fear of flying patient. And I mean, you guys have been in Atlanta, in the Atlanta airport, and the, you know, traffic and going there. And since 9/11, I can't even get access to a stationary airplane as easily. And so actually I treat a lot of panic disorder patients who get scared when their heart rate goes up. And we'll do the same thing. So we'll do little exposures. We'll have them run up and down the stairs. I'll have them hyperventilate on purpose for 2 minutes. I'll have them breathe in a straw. We will do these things to bring on these physiological sensations and get them used to it, and get them, and we do cognitive restructuring, some cognitive work with it, so they can understand that it's not dangerous. You know, in some cases it might not be comfortable, but it's not dangerous, because a lot of people with panic disorder are scared they're having, say, a heart attack or a stroke or they're going to faint, something bad will happen. And helping them to discriminate. All right, if I felt like this before and it goes away when I pull my car over, then it's probably not a heart attack.
That's really great to hear that, how you think about the technology, not just to do the technology for its own sake because it sounds cool and innovative, but really to do it when you don't have another better or equally good alternative. One of our pilot studies that we're about to just really start actually piloting with patients, not with just with our research coordinators, is doing like a sort of in vivo exposure of just like a simple stepping exercise that people could do in the home, given because of COVID, it forced us to think how to do things remotely, but it still is sort of the more real exposure to the visual activity in a carefully monitored way, to see if we can elicit some of the symptoms. And it'd be really interesting for us to incorporate like the SUDS or some of those other in the moment, and ask people if it's really generating some of those fears and anxieties as it did with your other types of patients, or does it just feel like exercise to them and nothing particularly anxiety provoking comes up with it?
Yeah, and you know, again, we do it in conjunction with the cognitive therapy to help them realize just getting the heart rate up isn't dangerous.
Right.
And, I would have people monitor their heart rate in different situations. I won't even tell you all of them now, but think of all the situations your heart rate go up. And that sometimes it was awkward to partners, but they would realize the heart rate would go up and come back down. It was fine.
Amy, do you have a question? I see your questions on there too. Would you feel comfortable saying your question?
Sure. It wasn't really a question. I kind of was just elaborating a little bit on the idea that Al put in the chat, just from a coordinator perspective and talking to patients like on the daily. We definitely do see a rise in fear and avoidance in physical activity, like little things like maybe just going up their walk up, because in New York, you don't get an elevator in a building above you. I think you have to have at least 6 floors to be able to get an elevator. So some of our patients may live on the 5th floor and they have to walk all the way up. And if they've recently had a cardiac event or a stroke event, the chances of them going up and down those steps just to do like regular groceries is limited, because they're scared that something might happen. They get scared of just their heart rate going up, of them breathing, of them sweating, just trying to not go back to the emergency room. Sorry, there's a lot of noise in my neighborhood right now, but there's just fear around those things. So I was just elaborating a little bit on that.
Yeah, exactly. And, I imagine you give them accurate information about what's good to do and what kind of aerobic exercises are good to do and getting more conditioned. But sometimes we'll do it in a gradual hierarchy, so getting them to get comfortable. For example, when I'm trying to get people to exercise, if they have like an exercise bike in their home, I'll ask them to do 5 minutes a day. Just to get in the habit for 5 minutes a day. You don't even have to change your clothes, just to get in the habit. And in this case, to see nothing bad happens. And then you can gradually increase it, again, with information and maybe with cognitive restructuring, helping them to understand what their fear is and what reality is. Are they just scaring themselves? What are good things to do?
Yeah, that's a really good point. Sorry, Ian, I didn't mean to cut you off, but
No. Thank you for the question and the discussion. I just want to make sure I got in one other big question that we've been having is, and especially hearing about your experience with the Grady patients. One of our big challenges is our patients are often middle-aged or older, and they're coming with medical events. They're not necessarily treatment seeking for psychological distress. And figuring out how best to recruit and engage our patients in treatment has been one of our big challenges. And I was just wondering if you had any, wisdom to lend to us in terms of, how do you earn people's trust? How do you get their engagement in something they may not have been looking for? Like, even how did you get some of the emergency patients do that first session, even in the emergency department setting? If you had any thoughts on that.
Yeah. So it's a little bit easier when it's clinical research and when we're doing an intervention, that we think might help. And then also most people are pretty altruistic, that even when you say it may or may not help you, but it will help other people that this has happened to, and it'll help research to know what to advise people. And most people are pretty altruistic. We also pay people to come back for assessments and try to make it as easy as possible.
I think we're at the hour. Does anyone have any last minute quick question? Well, if it's okay with you, Barbara, I will reach back out to you, because we actually would be really interested in maybe helping to test the app if there's a willingness on your side. We actually have a lot of partners who work in the emergency department. There's even another study led by investigators in our group that are focused on the sort of the stress in the healthcare providers, the sort of the nurses and the doctors in the emergency department, many who, were the frontline workers for COVID. So maybe we can even partner on something in that regard. But again, thank you so much in these middle of the summer, taking some time for us. Really, really inspiring work. I'm so glad that I reached out to you to invite you to come.
Yeah, no, thank you. It's my pleasure. You guys are doing great work. I'd love to keep talking with you. Have a good day.
Bye, everyone.